All right, it looks like we can get started. Hello, everyone. I hope you're all doing well today. My name is Kyle Herrera, and I'm the Clinical Education Coordinator for Belmar Pharma Solutions. I'd like to thank you for joining us for today's webinar on Dose Naltrexone. We are thrilled to be joined by two excellent speakers today, starting with Belmar Medical Director, Dr. Angela DeRosa, and the star of today's webinar, Belmar pharmacist and LDN expert, Samantha Lebsock. We expect the webinar to last around 30 to 40 minutes. It is being recorded, and we will send you a follow-up email to access the recording. If any questions may arise during the webinar, please use the Q&A function at the bottom of your screen to submit any questions. If you happen to have additional questions or want additional information after the webinar, please reach out to your team of Belmar Solution Engineers. With that, I'd like to introduce Dr. Angela DeRosa. She is a board-certified internist and HRT specialist. She was previously the Senior Medical Director at Procter & Gamble, but we are pleased that she is now the Belmar Medical Director. She is the founder and president of DeRosa Medical and DRM Integrative Health. She is also the founder and president of the Hormonal Health Institute, where you can find an array of online medical trainings and education. So with that, I'll go ahead and hand it over to Dr. DeRosa to get things started.
Thank you so much, Kyle. I really appreciate the lovely introduction. If you always want a mood enhancing boost, just have Kyle introduce you to anybody, and it's quite awesome. But speaking of mood enhancing, also as Kyle alluded to, Samantha Lebsock, PharmD, is our wonderful guest star for today. And having had many opportunities to work with her on many different things, she is still incredibly stellar at what she does, and in particular when it comes to her knowledge base in LDN. You can see she has quite an impressive clinical record. She's got a bachelor's in human biology and a doctorate of pharmacy from the University of Montana. And most importantly, at least in our regard, and selfishly, she's been a Belmar pharmacist and now working on the research side of Belmar since 2014. She's really become not only my trusted advisor, but also a trusted advisor for other providers around the country. And you can see she has extensive experience in doing educational conferences and podcasts on LDN. So I'm not going to waste any more time, and I'm going to turn this over to Samantha. And at the very end, I'll loop back with everybody with the question and answer session. But Samantha, take it away.
Thanks, Dr. DeRosa. So with that, I will start with low-dose naltrexone. So basically, we're going to discuss today the origins, how it works, indications, and go over some different dosing. So low-dose naltrexone was approved by the FDA for alcoholism and opioid dependence back in 1984. The following year, Dr. Bahari is kind of the founder, I guess you could say, of low-dose naltrexone. He demonstrated at these low doses that a lot of his AIDS and HIV patients actually had an improved immune system and had fewer infections and fewer deaths when they were taking low-dose naltrexone at about 4.5. So that led into Dr. Zagan and Dr. McLaughlin, who kind of did the background research to kind of support all of Dr. Bahari's initial findings. And what Dr. Zagan and Dr. McLaughlin basically studied was the opioid receptor, and they kind of confirmed this endorphin opioid receptor system, which is involved in nearly every biological system that regulates the immune system. So then over the next 30 years, Dr. Zagan and Dr. McLaughlin have published nearly 300 papers specifically just on the opioid receptor. So there has been extensive work done just on the opioid receptor itself. So LDN, basically there has been research showing positive results for the last 35 years in numerous different indications. So many that I can't even fit them on this slide. This is just a general overview of all the different indications that LDN has currently been used for, studied in, small case studies, things like that. So let's just start out with the basics. How does LDN work? Well, I like to describe it as LDN or naltrexone is an opioid antagonist. So what it does is it binds to the opioid receptor, and while it's bound, it tricks the body into thinking, okay, I need more receptors and more endorphins. And so what does the body do? It starts making more receptors and more endorphins. Then when it releases, it causes this upregulation of endorphins, which leads to an increase in the immune response. We'll get into that a little bit more. So the half-life is only 4 to 6 hours. So it's only bound, for about 4 to 6 hours, which is what we want because we want it to release. It does cross the blood-brain barrier. No real dosage adjustment is needed for renal or hepatic impairment, mainly because we're already at such low doses of about 1.5 to 4.5 milligrams. It is renally eliminated and it is very well absorbed orally. So back to the mechanism of action. So it's an opioid receptor antagonist, so it's going to regulate endorphins. It also is a toll-like receptor 4 antagonist on those microglia. And so this is the pathway that's thought to cause this anti-inflammatory. It's going to stop the anti-inflammatory cytokines from being released. This will be important for all of our inflammation indications that we see later on. So what are the indications? Well, most importantly, autoimmune diseases. This is probably our main indication that we see LDN used for. So a thing I like to note right off the bat is that most autoimmune patients already have decreased endorphin levels. So if we can give LDN and upregulate those endorphins, then we can help modulate the immune system. LDN specifically for autoimmune has been shown to increase quality of life and decrease any flares or fatigue. Dosing is usually around 3 to 4.5 milligrams once they get stabilized. So we're talking inflammatory bowel, Crohn's, MS, all sorts of different autoimmune diseases here. This is a very broad category and you can talk on this for days. Thyroid dysfunction. So Hashimoto's and Graves' disease. So basically what's happening here is your body's antibodies are attacking the thyroid in one form or the other. In Hashimoto's, the antibodies are destroying the thyroid gland, and in Graves', the antibodies are actually stimulating the thyroid gland. So if we can control these antibodies, then we can help fix these patients. So what we've seen is that when we give LDN, we can drop these antibodies, and then we can actually get some better function of the thyroid gland. The main thing here that needs to be pointed out is that these patients usually will have to have a dose adjustment on their thyroid after about 8 weeks. So if you are going to use LDN for your thyroid patients, please check their labs again after 8 weeks, because most likely the dose will need to be decreased. I also like to point out here, if you have a patient who's you can't get them under control, LDN helps. Maybe add some selenium, because selenium is also shown to decrease some antibodies by about 40%. So that's another good tip for specifically thyroid. Pain. So pain is very interesting. There's a lot going on with pain in LDN. Typically, none of our pain patients are on opioids at the same time. Generally, they've already all been tapered off opioids. So first and foremost, it's an opioid receptor antagonist, and then it's going to stop that toll-like receptor 4, like I said, that inflammatory pathway. It's going to block toll-like receptor 4 on the macrophages or microglia and stop those excitatory cytokines. So that's the main kind of anti-inflammatory stuff we're talking about. Generally with pain, you're looking at about 4.5 milligrams a day. Sometimes you'll see a little higher at like 6, but generally it's around 4.5. So this is a new thing that's slowly been in the research. There's been difficulties here. So ultra low dose naltrexone. So when we say ultra low dose, we are talking between 1 and 4 micrograms. So very, very small dosing. Basically, what the research is showing here is this hormesis, or when you give a low dose of an antagonist, it can conversely act as a weak agonist. So there have been some studies and case reports that has shown that you can actually decrease chronic opioid users' opioid dose by about 40 to 60% if you give them microdosing. And it's also been shown to help like reset these receptors back to their resting state. Because as we know, opioid users keep having to use more to get the same effect. So if we can reset these receptors, then they don't need as much. This would be obviously a game changer in the opioid crisis that's happening in the world, right? Well, here's the issue. There's not really a lab out there that can test for 1 microgram in a finished product. So we have partnered with a lab, and we are working on getting microdosing for our providers and patients. We have a lot of pain clinics who've been requesting this. So we are hopeful that we will have this all figured out with the lab in 2022. So if you are interested in this, or you have some background, you are a pain doctor, please reach out. We'd love to get you on the list. We'd love to discuss with you about some upcoming ideas that we want. My email will be at the end, but this is something new. And so if we can prove the dosage of a final product, I think this could be a game changer basically in the opioid crisis. Another thing, so let's get back to low dose naltrexone, right? So we're talking 4.5 milligrams. So with a lot of naltrexone patients, they're not taking opioids, right? So if you have a complex regional pain syndrome patient and you need to put something on board for breakthrough, that's where I think ketamine is a great choice. Sublingual ketamine works at a different mechanism. It blocks NMDA receptors. So a lot of times we'll see a 10 milligram sublingual tablet, and they can take, you know, a sublingual tablet up to 4 times a day and see really good benefits if they do have some breakthrough pain when they're on, you know, daily naltrexone. Another thing to note with LDN and ketamine is that it has been shown to help increase dopamine levels in the brain. So it could also help with mood in that instance, especially with these patients who are chronic pain patients. Complex regional pain syndrome is known as like one of the most difficult pain syndromes to manage. Mood disorders. This is newer. I really think this is an emerging, I guess, indication that we have seen. With this, you're going to see more twice daily to 3 times daily dosing. And what we've really seen is hypervigilance decreases, excuse me, anxiety decreases. And so obviously this is taken during the day, and we're going to see, like I said, twice to 3 times daily dosing. And usually it's around 0.06 milligrams per kilogram of body weight. Now, something interesting here is that some of these patients who start out, you know, with these higher dosage, if the dose is too high, they might start telling you they have all of a sudden anxiety, or they have a headache, or they have nausea that's not going away. So that should be a good clinical sign to you that you might need to back off their dose slightly. This is kind of something that we've been seeing more frequently when the dose gets a little bit too high. Gynecological disorders, PCOS, infertility, and endometriosis. A lot of this is inflammation, right? That's what I would say the primary mechanism of that is here. We have seen, and I do like to point this out, women who say that they can't get pregnant, they haven't yet gone through menopause, they start LDN for some autoimmune or, you know, maybe endometriosis, and then they've gotten pregnant. So please be warned that that can happen. We also have numerous infertility clinics that have started using LDN for patients who might have recurrent miscarriages and they can't figure out why. Maybe they can't, their tubes are clogged. There's a bunch of different indications, and generally what these offices are doing is they're giving naltrexone through pregnancy all the way up to about 37 weeks until they're about ready to deliver, and then they stop the naltrexone. Very interesting stuff. There's whole clinics out in Ireland that are using LDN specifically like this. But like I said, it's really picked up here in the United States as a new alternative for infertility. Dosage is usually around 4.5. We're looking for that anti-inflammatory effect here. Weight loss. So naltrexone and a combination with bupropion is actually FDA approved on the market called Contrave. Specifically about this, that naltrexone is extended release. So when you're using naltrexone for weight loss, generally I see it used twice a day, right? It's going to block this reward system or block that endorphin rush, right? And so it can also help regulate the hypothalamus, really in that appetite regulatory center. So using naltrexone this way, usually I see about 4 to 8 milligrams dosed twice daily, and we've seen some pretty good results with this. People generally like it. We do have a couple combination formulations that we like to use. We like to combine it with oxytocin, potentially to help with mood, and then some methylcobalamin to help with some energy. And like I said, generally recommended to dose twice daily, right? Because we're trying to stop that reward system. So miscellaneous indications, like I said, we could talk for days on just each one of these. Cancer is very interesting. A lot of people will see different pulse therapies here, maybe 4 days on, 3 days off. I see that more used for cancer than for anything else. A lot of times they like to use daily naltrexone with maybe 3 days on, 3 days off of CBD. That's also very popular. It's really specific on the cancer. And so while we do see some of these, I do like to refer a lot of our providers who have specific cancer patients that they want to talk about to Dr. Khan. He lectures all over the world about LDN and cancer. He's located in Canada. And so he had so kindly allowed us to put his email here. So if you do have a specific cancer question that we can't answer, happy to refer you to Dr. Khan. He is very knowledgeable there. Traumatic brain injury, basically leaky gut, leaky brain, right? So if that's happening, we can regulate those tight junctions, get in some LDN, decrease inflammation, right? That's the main goal when you have a traumatic brain injury. We have to get the inflammation under control. So there has been case reports using LDN and traumatic brain injury. Restless leg, usually I see a little bit lower dose here, usually about 2.5 milligrams for restless leg. Lyme disease, this is for mainly like your long haulers. Maybe they have brain fog, fatigue, things like that. I think this is definitely a good choice here for your chronic Lyme disease patients. Parkinson's, there's been benefits. Memory with the brain fog, like I said. Sleep is interesting. So sleep is one of the side effects that you'll see that we'll discuss here shortly, but sleep, once you get maintained on naltrexone, can actually be improved. So if you think about it, if your immune system is off and there's constantly excitatory cytokines going off, you're not going to have a well-rested sleep. If we can stop all those excitatory cytokines and get you on LDN after you've been maintained, then a lot of times patients will report they've had better and more well-rested sleep while they're taking naltrexone. So a lot of times we tell patients, just get through those initial symptoms that subside within 2 weeks, and a lot of times you'll have the best sleep you've ever had. Diabetes, blood sugar has been shown to be better well controlled. Autism is very interesting. We have seen children who have more of the aggressive form of autism actually improve when they take about 1.5 to 3 milligrams of naltrexone. Here's where sometimes I see a topical cream preferred or over like an oral tablet or a capsule. So that is a very interesting thing that we have seen. Chronic fatigue, like I said, it does help with chronic fatigue. A lot of times we like to pair this with a mitochondrial cocktail. With a lot of chronic fatigue, you'll see that there is mitochondrial dysfunction. So if we can fix the mitochondrial get some naltrexone on board, generally our patients are very happy. Mast cell activation syndrome and mold, more of newer thoughts that naltrexone has been used for. If we can get, you know, the histamine release under control, then if we can get some naltrexone on board, a lot of times these patients will do better. Obviously, we have filler issues when we do mast cells, so that is very patient dependent. So what are our popular formulations? Well, we have tablets. We use microcrystalline cellulose as our filler. We have sublingual tablets. We also use microcrystalline cellulose. The thing about sublingual tablets is naltrexone tastes bitter and terrible. Not gonna sugarcoat it. Basically here, it doesn't taste good. So a lot of patients don't like sublingual tablets. What I tell patients is you can crush the tablet. They're all immediate release. So you can crush it, put it in applesauce, put it in something else, and that's usually an easier way to take it than under your tongue. Capsules, we offer capsules with different fillers. Like I said, mast cell patients generally might need different fillers. Maybe you have a patient with a sensitivity. Our popular fillers besides microcrystalline cellulose are sucrose, rice flour, or vitamin C are very popular. Creams are also popular, except they're a little more difficult with the beyond use state. We only have about 30 days for the beyond use state. So if we, this is where I like to tell patients, especially children or parents, you know, to just crush that tablet. It's usually a little bit easier and a little bit more cost effective for the patient. But creams are easy to apply. You know, you could put them on the inner wrist, any thin skinned area. We just have a little bit more varied absorption when we use creams. Oil suspensions, they're great, except the one thing with them is they taste bad. Like I said, naltrexone is very bitter, but they do have a better beyond use state. So if you have somebody you're trying to taper very slowly, then maybe you want to use an oil suspension so you can taper them a little bit easier. So dosing. So most commonly, I'm seeing dosages of about 0.5 to 4.5 taken daily at bedtime. This is where tablets come in to be very nice because they're scored. They're scored in half, so you can break them for easy titration. Not all patients are going to be on the same titration or on the same dose, so it's very dependent. I will say my most common titration is about a half tablet every day at bedtime for a week, then going up to a full tablet at bedtime for a week, and then 1.5 tablets thereafter. And then you can write a second prescription for just a 4.5 if that's where they get to. One thing I like to say here is you should just straight up ask your patients right at the beginning, are you chemically sensitive? If they tell you yes, then you might want to do a longer titration. You might want to have them take it for a week, 2 weeks, or maybe 30 days to really stretch that out. If they're a little bit unsure, maybe we start a little bit lower than a 3 tablet. Maybe we start with a 1 milligram tablet. So it's very patient dependent, and not all patients are going to get up to the same dose. So that's where tablets become very nice because the patient has a little bit more leeway to play with their dosage. Side effects. So like I said, generally side effects subside within about 2 weeks. So this is an interesting survey that the LDN Research Trust performed on about 1,800 patients. And basically they asked their followers, what side effects did you have? And so this was in the autumn of 2020, and they reported, well, first off, 54% of them reported that they had no side effects at all. So this is very patient dependent. 50% say they have them, 50% say they don't. Of the people who reported that they had side effects, the 5 top reported side effects were vivid dreams, sleep disturbances, headaches, upset stomach, and fatigue. And like I said, these generally go away within about 2 weeks. So very minor side effect profile. What are the contraindications? Well, really, if you have a hypersensitivity to naltrexone, that's really the only contraindication that I see. So interactions. Well, it does interact with opioid pain medication, right? Because it's an antagonist. I do put an auxiliary label on every script that we send out, basically telling patients to consult their doctor before they take any narcotics. We have had some patients who didn't realize something they were taking was a narcotic. Even these low doses, some patients who are very sensitive can have some type of reaction. The main thing there is we don't want them to keep taking opioids, trying to overcome maybe the naltrexone blocking it and accidentally overdose. So we do like this label on every script. With that being said, I do have providers who dose maybe an opioid in the morning and naltrexone at night. It's kind of a provider preference. Generally though, most of my patients are not on opioids when they're taking low dose naltrexone. If your patient has a scheduled surgery or you have a scheduled surgery, we generally recommend 24 to 48 hours prior to surgery to stop the naltrexone, and you can just restart it once you are off any opioid pain medications. Some other special things I like to talk about, vitamin D. Most integrative medicine doctors love vitamin D. Make sure that vitamin D is up to recommended levels, 50 to 80. I have 50 to 100 here. It does regulate tight junctions, which is a big thing for all of our gut health patients, right? Pregnancy. Like I said, there are numerous clinics who are using low-dose naltrexone for infertility. Generally, they stop at about 37 weeks before the birth, but they are taking it while pregnant. We've had no issues. Breastfeeding, this is kind of a risk versus benefit. It is excreted in the breast milk, studied at those higher dosages of the FDA approved product of 50 milligrams, 100 milligrams, 300 milligrams. At low doses, there hasn't been any trials, but I do know many prescribers who do use LDN while the mother is lactating and breastfeeding. So I do like to say that. I think it's more of a risk versus benefit there. Please have your patients try for 3 months before they say that it doesn't work. I have patients who start in a week and notice a difference, and then I have patients who don't notice a difference till the end of 3 months. But I do think 3 month trial minimum is what needs to happen for any and all indications of naltrexone. I will say we have a lot of patients who call and tell us, I've been on naltrexone for a year and everything is great, everything's fine, I don't need it anymore. So they go off, and usually within about 3 months they have another flare, and they call us back and they refill their prescription. So generally these patients are taking it lifelong. Another big thing, not all patients are going to get to 4.5. It used to be that 4.5 was kind of the gold standard, and that really isn't the case anymore. Really, I find that if you're well controlled at 3 milligrams and you try to go up and you have a headache and you don't feel as well and the symptoms aren't going away and you go back to 3 and you feel great, then 3 is probably your sweet spot. So every patient's going to have a slightly different sweet spot. Usually it's around 1.5 to 4.5, maybe 6, but every patient might be slightly different. And so that's where tablets come in. It might be nice to play around with their dosage a little bit. Frequently asked questions, children's dosages. Like I said, we use LDN in children. Here's a nice recommended starting dose for you guys if you need it, 0.1 milligram per kilogram per day. Maybe taper them a little bit slower, maybe do a 2-week taper. But generally, I still see about the same dosages for children as I do in adults. Do we go higher? Yes. I have some people on 36 milligrams. I usually see this when doctors are trying to control inflammation and they're basing their dose on like C-reactive protein or some of those labs, and we're still seeing good results there. Morning versus bedtime. So historically, endorphins are thought to be made at bedtime between 2 and 4 a.m. So that's why naltrexone was studied at bedtime. But more and more, I have patients who are taking it during the day. Maybe they already have insomnia, and we're seeing great results. So if you want to take it during the day, that's fine. If you're seeing great results, great. Keep taking it during the day. Just try to stay consistent. So Belmar Pharmacy, we are a preferred pharmacy on lowdosenaltrexone.org. We do offer the tablets. They're scored for easy titration, especially when you're trying to find that patient's sweet spot. We also perform, our tablets have third-party testing. And then I really like to point out that our pharmacists see it all. And so they are the experts. We are the experts in LDN. 800 LDN scripts go out of our door in 1 week. So we kind of see it all. So we are open to any questions, any patient questions, call us, and we are happy to discuss anything you may want to talk about with LDN. So with that, that is my quick little seminar for you guys on naltrexone, and I think we have quite a few questions.
Yes,
Dr.
Sam.
DeRosa?
Yes, thank you so much. That was highly informative, and a lot of the questions, we had some pre-submitted and there's some popping up. So you answered a lot of them through the lecture. So I'm going to try to sort through the ones that didn't seem to get answered, but quite a bit of interest. So, but thank you. That was wonderful information, Sam. So from one doctor here, with a patient with chronic pain on buprenorphine and naloxone treatment for opioid abuse disorder, can LDN be given concurrently to address the pain?
So I would try to get them off. They're already on, they're on naloxone, did you say?
Yes.
So I would say no, we'd have to try to taper them off the opioid first before we should introduce LDN. Like I said, we do have some pain doctors who like to use naltrexone to taper patients off naltrexone. It's a little bit more of a specialty, but reach out to me specifically about that, and I can send you some protocols that we have doctors who do that. Actually do that for a living, basically.
Next question, does LDN interact with birth control pills?
It does not. You can take LDN and birth control together.
And are these indications FDA approved?
No, so naltrexone itself is FDA approved at 50 milligrams, but all of this is off-label.
Is there any experience with LDN or with your clinicians for post-COVID long haulers?
We do have some providers who are using it for post-COVID long haulers. I think it makes sense. These patients have brain fog, fatigue, their immune system has been out of whack. A lot of times they have a lot of cytokines that have been spread out there. So if we can start modulating their immune system, yes, I think naltrexone will be great. Once more studies have obviously gotten started using low-dose naltrexone and for COVID long haul.
Okay. ICD codes with prescription and insurance coverage. Have you seen folks get that coverage?
So most compounding pharmacies are not contracted with insurance companies, but what I think you will find is that actually the cash price is cheaper than what an insurance copay would be. So in reality, 90 tablets will only be $55. So we're talking $18 a month here, where I think if you were to try to run it through insurance, you would find that the copay is extremely higher than that.
Absolutely. Let's see. They're asking about naltrexone to block the effects of alcohol. Have you seen a lot of folks using it with alcohol abuse?
Yes. So like I said, it is approved at 50 milligrams for alcohol and opioid abuse. But I do see naltrexone used, low-dose naltrexone used in any type of addiction disorder. Like it does, it blocks those endorphins. So if you take it during the day, technically prior to any type of addictive event, it should block that endorphin rush that patients get. I even have sex doctors who use it for sex addicts prior to having sex, and then it blocks that endorphin rush. So yes, I do see it used in a bunch of different addiction cases.
Great. And what about low-dose naltrexone for anti-aging, like skin, hair, anything of that sort?
So hair, yes, I have seen some case studies to help with hair loss. I do have some patients who take it for an overall well-being, and I think they really like it. I don't necessarily have any studies for using LDN for anti-aging, but I don't see why not. If it helps regulate your immune system, it's always good to help boost your immune system.
And do you see any issues for people who don't have autoimmune diseases, or the things that you're talking about that just take it for just to feel better, any long-term consequences of doing so?
No long-term consequences. Like I said, most of it is long-term. I have a lot of patients who take it just for mood, because there has been obviously some depression, some anxiety, and it's shown some really benefit there. So I do have patients who just take it even just to help their overall mood.
That is all the questions I have, which were plenty and wonderful questions. Thank you to our audience for participating with that. But Sam, thank you so much for all of your information. And you can see here, Sam has her contact information and direct line listed here. I hope you take advantage of her exceptional skill set. But if anybody has any further questions after this and not comfortable just participating on this webinar, please just let us know and reach out to her. We just really appreciate all of our support from our clientele, and we appreciate your time today. Thank you so much to everyone participating, and thank you, Sam.
Thank you.